We invite the Dr. Hassan Althani speak about aorto-enteric fistula challenges and the outcomes, Qatar local experience.
Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. And good afternoon. I would like to thank the organizing committee for the kind invitation and honor of the podium. I'm going to present our experience on aorto-enteric fistula, challenge, innovation, and management and outcome. I have nothing to disclose regarding this presentation. Aorto-enteric fistula is a rare, life-threatening cause of massive GI bleed. Without surgical intervention, it is associated with 100% mortality. The classic triad, abdominal pain, GI bleed, and pulsatile abdominal mass is present in only 23% of the patient. And herald bleed, 70% of the patients survive 6 hours after the initial bleeding, and up to 50% survive 24 hours. So the herald bleed should be taken as opportunity to intervene for these patients. The etiology of aorto-enteric fistula is the commonest is abdominal aortic aneurysm, followed by foreign bodies, malignancy, the presence of prostatic graft, and the trauma. They are classified into a primary and secondary, with a very low incidence in the primary and also in the secondary. There are subtype of 4 types, primary, and for the type 2, 3, and 4 with the presence or related to a graft. They also subdivided based on the location of the anastomosis. 2 major concerns should be taken in consideration when we're treating these: the early bleed control and the late presentation of the complication, mainly bleeding and infection. During the past few years, we had 10 cases, 2 primary aortoduodenal fistula, and the rest are secondary, 2 from foreign bodies, and 90%, which is 9 patients, are male and 1 patient are female. And in hospital, 30 days mortality was 40%, and the total in-hospital mortality was 50%. So it's associated with very high mortality. To illustrate this, difficulties in terms of diagnosis, this is a case number 3, a patient who visited the emergency department and a private clinic 7 times. And on the last time, he had motor vehicle accident because he lost his consciousness, and he was brought to the trauma room, had pan-CT scan. The CT scan showed that there is some air pockets, some inflammation around the aorta, descending thoracic aorta, and query related to the trauma. But on the other hand, there was white cell count of 61,000, and there was a concern that this patient had maybe a leukemia or leukemoid reaction. He vomited a large amount of blood and underwent endoscopy. The first image, if you can see here, it's blurry and you can't see much, but there was a lot of blood in the stomach and duodenum. And we revised the CT scan with the radiologist, and there is actually extravasation of contrast going to the esophagus. The patient was taken back to the hybrid OR, had endoscopy. After a wash, you can see that there is actually a clot coming from the mid-esophagus down, and he underwent TVAR on the same time with aortogram confirming that there is communication. We also stented the esophagus in order to decrease the contamination, and the patient did quite well and discharged home after the removal of esophageal stent. And he continued on oral antibiotics for life. Second case is a patient who had actually a sleeve gastrectomy, a young lady, the only female, and she presented with abdominal pain and a large cavity with a CT scan. She underwent CT-guided drainage, and during the drainage, she had also a contrast, which showed that there is a communication between the cavity and the stomach at the site of the sleeve gastrectomy. She had, after that, a massive GI bleed, so she was taken and stented and settled down. But later on, after the stent was removed, she had a second bleed. So she was taken to the hybrid OR during the attempt of angioembolization, which did not control it. Then we proceed with the stenting of the aorta to control the bleed. Endoscopy showed that the angioembolization was in the stomach, so she underwent a stenting of the esophagus and was removed. The patient later on came back with massive GI bleed and showed that, the graft was eroded into the lower esophagus, and PET scan confirmed that she has an infection also around it, of course. The patient in the beginning refused surgical intervention, but later on accepted because she continued to bleed, and under left heart bypass, she underwent a resection, reconstruction of the descending aorta, and also esophagectomy. And later on, the esophagus was reconstructed with the transverse colon, and she did quite well. The fifth case is a patient who actually had aortic repair and presented with massive GI bleed. Endoscopy showed that there is an ulcer in the fourth part of the duodenum with pulsatile bloody connection. And of course, the patient had a CT scan confirming that there is a communication between the graft and also the fourth part of the duodenum, so underwent a repair. The stomach and the rest of the endoscopy was within normal, and the finding in the surgery, you can see that the duodenum is full of blood and the graft was connected. So it was replaced with rifampin impregnated graft, and the patient continued antibiotics. The sixth case is a patient who actually had ruptured AAA, underwent aorto-iliac repair, and did quite well. He presented later on with fever and melena, and the CT scan showed that there is actually an air around the graft, and of course the patient had aorto-enteric fistula. And intraoperatively, endoscopy confirmed the finding, and he had a replacement of the graft with a pericardial reconstructed tube graft with bifurcated iliac. Postoperatively, the patient was maintained on antibiotics, and 6 months down the road had lower back pain, showed that he had a pseudoaneurysm at the distal part of the bifurcated graft, so underwent EVAR to control this pseudoaneurysm, and did quite well. He is continued to be on antibiotics, and he is 2.5 years down the road after this procedure. The seventh case is a patient who's an elder, had a transplant, refused any intervention until he had actually GI bleed. Of course, he had a ruptured AAA, and after the repair, while he's in hospital, he has also distended abdomen, dropped his hemoglobin, and he had a leak from the distal left iliac anastomosis. He was taken to the hybrid OR. Balloon was placed to control the bleed, and he had bilateral iliac stenting, and actually did well with this. For the time reason, we will stop at this, but in conclusion, these patients actually show that aorto-enteric fistula is a challenging pathology. It requires multidisciplinary team approach, and endovascular procedure for bleed from aorto-enteric fistula is a bridge for a definite surgical intervention. Thank you for the kind of presentation.